Got it.
So Hank Aaron, it's great to talk to you.
Well, it's good to talk to you again, Harold.
There, so why don't we start with sort of who you are and what you do?
Well, I'm an old economist, now largely retired, sitting in a very nice room, as you can see, in my apartment, and
Yes.
talking to you.
Now, what are some of the roles that you've had in economic policy making over the years?
Well, I got my degree, and right after that, a few years after that, I went down to Washington to be a member of the staff of the Council of Economic Advisors. And for the first time learned that the application of economics really has a direct impact on the formation of public policy. That hooked me. I stayed in Washington and have spent most of my time since then at the Brookings Institution, taught part-time at the University of, well, full-time and then part-time at the University of Maryland. I've been back in government on principally on one occasion when to be head of the Office for Planning and Evaluation at a cabinet department now split into separate pieces, then called the Department of Health, Education, and Welfare, which at the time housed the Social Security Administration, what is now the Department of Education, as well as more traditional welfare and health programs.
So you had the job that's now the ASPE, now the Assistant Secretary for Planning and Evaluation.
That's the exact title, yes. Back then, though, I think were better times. It was a plum position for economists interested in public policy and domestic social and economic policy to go to. And in many respects, I think had the strongest group of analysts on issues relating to income security and health policy that you could find in the country. Of course, things have been democratized since. That talent has spread around and much more talent has come into the field, so that I think the particularity of that occasion, of that time, no longer exists.
Now, I understand you're doing some stuff now that's related to Social Security.
Well, I was for a while chair and then member of the Social Security Advisory Board. The chair is appointed by the president, and I was appointed during the Obama administration. The saga behind that is rather interesting. I was appointed right at the beginning of President Obama's first administration. The personnel system, which never really attracts, I think I may be insulting somebody here, but never attracts the strongest candidates for government service, was not operating on all cylinders. And I think some of the blame here goes to the administration, but a good deal of it goes to congressional procedure. That particular position had to go through the Senate Finance Committee, which has become a veritable swamp of bureaucracy with respect to investigating financial and other aspects of candidates. And it just takes forever. Well, in my case, it took more than the entire first administration of President Obama. I wasn't finally confirmed until approximately 4 years after my nomination had been initially submitted. And I had to resubmit papers over and over again because new people took over the job of vetting, and each one had to, of course, do it his or her own way. So I started in that job, a very part-time job, at the beginning of Obama's second administration. I had a term to complete and a full 4-year term to continue, which took me, of course, into the Trump administration, at which point I was not the flavor of the day. The president has the right to select the chair. And after about 6 months, it wasn't the highest priority for the Trump administration either, understandably. Somebody else was picked to be chair. My term ended a couple of years ago.
Gotcha. So we're talking in a video that will be available to students in Economics for Social Welfare, Crown School 454. And it's been a while since you've been on U of C campus with us, but I thought we'd start with, given that you've had 50 years of policy experience, what do you see as the greatest contribution and insight that microeconomics brings to the policy arenas that we were just talking about?
I think in a way, the major contribution is one that if it's all you learn, you may not be as constructive as you could be.
Mm-hmm.
And that is the strength, the analytical power of the rational actor model on which microeconomics is based.
Mm-hmm.
It is a very powerful instrument for developing hypotheses, for bringing to data in order to try to order those data in a sensible way. At the same time, if it's all you learn, I think you will not be nearly so useful as you could be in matters of public policy. And the reason for that could be encapsulated in the critique of the rational model that has come from behavioral economics. More broadly, it's the importance of bringing to bear our understanding of how that rationality assumption fails. And from an academic standpoint, I think the importance of understanding at least some basic lessons that one can learn from psychology and sociology. So it's one of these things where it's a starting point. Models are tools, not endpoints. They are tools for helping to organize one's thoughts about public policy question. And so in the strongest terms, I would urge people who are interested in social welfare issues to take a couple of years of economics courses, starting with principles and then branching out into something else. Take a course in the application, say in health economics, or if there's one on income distribution and the impact of social policy on that, do that, or other similar courses, whatever really floats your boat. Don't stop with principles, go on and do some more, and then understand that that's the beginning point for thinking about the policy questions that drive one, not the end.
That's really helpful. By the way, you'll be astonished to know, of course, as you and I know each other fairly well, as a liberal Democrat, I'm the House conservative at the Crown School. And you mentioned health economics. One of the ways that actually the basic framework of microeconomics can be very helpful from a progressive perspective is just the idea that hospitals like the University of Chicago Medical Centers are economic entities that respond to incentives and even and that in our pricing and in which patients we pursue and so on, and that it's important for us, if we're trying, say, to achieve the aspiration of universal coverage, to try to understand how institutions like ours are going to respond to the incentives that are created by different insurance arrangements, things like that.
Not just that, but also the inertia with which they respond. When you started talking, the thing that came to mind was the enormous gap between what medical science has established as optimal practice in various areas and the degree to which it is applied in that practices follow that those prescriptions. Furthermore, the amount of time it takes for behavior to modify in response to new information. So it's in addition to incentives, it's inertia and sluggishness, the formation of norms and habits. And now I'm getting into the realm of, I guess, of psychology and of sociology. The slowness with which we respond to new evidence, is an important factor that anybody engaged in, say, hospital administration or in the formation of policy for a city council or for a state need to keep in mind.
Now, you said that there's some aspects of the rational actor model that you think can occasionally lead you astray. I take it one of them is a lack of awareness of institutional realities and also the ways that individual decision making is affected by our psychological lives
and our interests.
Say more about that.
Well, it is there's a whole field in regulatory economics related to something called regulatory capture, whereby organizations that have strong economic interests manage to infiltrate, if you will, or be infiltrated by regulatory people with regulatory expertise, so that what was institutions that in some cases are expected to regulate on behalf of the public interest, one has to at least be aware of the risk that those interests may be diluted by well-informed resistance from people whose economic interests would be adversely affected by such actions.
One of their assignments in the current week's homework, I basically lay out the different ideological camps in American politics, and I ask the students to identify a key insight and a key lacunae for each of these perspectives. And if you think about the libertarian critique of the regulatory state and the possibility of regulatory capture and the use of the state, say, to reinforce cartels and things like that, that's very resonant with what you're saying now.
But it also provides advice as to how to set up regulations, regulatory organs or agencies to the maximum extent be resistant to such risks and possibilities, as this model highlights.
So how could we make the regulatory state more robust against that capture risk?
I don't have any general principle that I can give you about it. I think it would involve, to a significant degree, rules on where one would look for members of regulatory organizations. But that calls to mind an example that cuts the other way. The Affordable Care Act called for the creation of a regulatory entity that, to the best of my knowledge, has not yet been appointed, although the law was passed 10 years ago, or close to it. And one of the reasons was that the law contained specific categories that could not be represented among the membership, and thereby made it virtually impossible to put together the kinds of expertise one would need to have in order to carry out the charges that were contained.
Can you make that a little bit more concrete?
I cannot. Because of a failed memory, I'm sorry.
That was, as I recall, you and I both wrote op-eds about precisely those issues in the Affordable Care Act. And one of the ironies was that legislators completely understood the collective action problems that some of these regulatory structures were trying to address. And that was a specific reason why legislators opposed putting real capacity in some of these bodies. That one of the problems that we have with the United States Congress is that one of the most valuable things you can do as a legislator, if you're a liberal congressperson from Minnesota, and Medtronic has a big facility in your district, and there's some work that Medtronic does, which is kind of hard to justify in terms of its medical cost effectiveness, or the comparative effectiveness research just doesn't support some particular lucrative activities that Medicare patients might have that would benefit that company. Well, you can make some quiet phone calls to Medicare and say, hey, what's going on with this thing being reimbursed? And of course, there's some value in the thing. So you're not going to make that call for Bernie Madoff, but you're going to make it in these cases where there's something of marginal value. And legislators don't want to see structures that would centralize those decisions in a way that would eliminate their own individual power to do things for their own constituents. And that collective action problem is a real issue if you're trying to contain the cost of healthcare.
It really is, and it's certainly comes up in the case of new drug approvals or durable medical equipment, for example. I can't give you specific cases, but I could at one point.
Well, you're still running circles logically around me. Now, if you think about, a lot of our students will be in local governments doing work, say in the Medicaid program or in housing, things like that, and they'll be in line jobs implementing public policy. Are there particular aspects of economics that you would think would be helpful on the front lines of service delivery that people might be thinking about?
Well, the obvious one is that economics emphasizes budget constraints. And if you're in that kind of a position, the one you just described, you as a city administrator or legislator or simply employee are going to be confronting the budget constraints that under which the city operates every day that you work. You will also be dealing with entities that equally operate under budget constraints. When you started to ask the question, my thought about what you should do in order to prepare yourself for a job in city administration dealing with health is to find a way, if you can, either as a student being an intern or for term project, or even after you leave as a part of your job, to try to get inside the organizations with which you are actually dealing and live their lives for a while, or at least study them, try to understand the incentives and constraints under which those whose behavior you would modify operate. This lesson was driven home to me as an economist a long time ago when I decided I wanted to get into health economics, a field that I was unfamiliar with theretofore. And I had the good fortune of collaborating with a physician and getting inside, actually seeing how hospitals work, talking to physicians at some length. And I have to say, there's just nothing like it for forcing somebody who is accustomed to sitting in an office working with, at that time, low power computers and pencil and paper. Now, of course, much stronger computer power and vastly more data. But to give one a tangible sense of the world in which one would apply one's analytical expertise or techniques. I just think together with the analytical tools that graduate school inculcates, whatever field you're in, actually experiencing the governmental or service delivery entities from the inside is enriching to a vast degree.
That's really helpful, and there's a kind of humility that comes with that too.
Exactly.
That you're bringing some insights that are valuable from your training, but you're also understanding that there's an awful lot you don't understand, and
something more than that. There's, when you're in graduate school, why are you in graduate school? You got there because you were a good undergraduate student, that you were there because you were a smart high school student. You're now at the sort of academic acme, maybe not, the whole graduate enterprise is one that not only teaches skills, but teaches a mentality of expertise, perhaps a little bit of arrogance. And one learns from direct contact with people working in government, not at the highest levels. People who have what might not seem to you as a graduate student, the most prestigious private sector work. These people are learning a lot about whatever it is they are working on. And they probably, in at least a number of fields, know a whole lot more than you do. So it's not just, it's a special kind of, not just humility, but respect.
It's interesting, John Updike, when he was asked about his short stories, he said, it's important to give the mundane its beautiful due. And there's so many aspects of service delivery that seem very mundane, but that are so critical. And, certainly in the work that I do on first response, it is astonishing how often the difference between I'm really responding super humanely to this person in a mental health crisis versus I'm not, comes down to sort of very mundane things that the people in the environment understand, that if it's Saturday night at 9 o'clock in a high crime neighborhood, you really can't expect a police officer to routinely spend 45 minutes helping someone calm down when there's all kinds of other things going on that are going to be urgent competition for that person's time. That officer is going to be a lot more humane Tuesday at 2 o'clock in the afternoon than Saturday night at 9 o'clock, in the highest crime neighborhood. And and the people who are in these systems in a tactile way understand that, and they can think about how to design responses to accommodate that reality. You're not walking in, there's going to be a million things like that you're just not going to know. And there's nothing in particular about whatever training you have in your academic life that's going to teach you that, except for the admonition to come in with that kind of respect for local knowledge. And it is so I think that's a very valuable point. What have we not talked about that we should talk about before we bid each other adieu?
Gee, I don't know. Probably we haven't talked about the Ukraine or the next Supreme Court term.
We have not. Well,
let's not.
Yes. We'll turn off the recording before that conversation. There. Now, one thing we have not talked about, which will come up later in the course, is sort of the broader institutional designs of American government. And one of the things that you got to actually when you talked about the delays of your own confirmation, and we do have some serious organizational challenges in the way our government is set up, both legislatively and in the executive branch, that do hinder us. It's kind of, I always find it very humbling that I needed to get an early COVID vaccine because of my caregiving responsibilities. And I called our local public health clinic and I got 11 messages from them that said, we will call you back the next business day. And I never got a call back. And the same happened to me at all the public health clinics around here. And I was thinking, if you were a Domino's Pizza and you operated like that, you just go out of business.
Yeah.
And the sort of mundane organizational incapacities in the public sector can be quite profound. And one of the things, especially when I think about our blind spots as progressively minded policy analysts, there's an awful lot of things that in the competitive private sector are actually done really well because you have to survive, that in government are not done well. If I was trying to hire someone at Google, I needed Hank Aaron to be in a key policy role at Google. They're not going to spend 4 years, they're not going to dawdle for 4 years to get you on board. And it is a humbling thing that to see things like that.
You asked about one thing we might talk about. It. This occurred to me. It's something I've observed over time. There is a tendency, a reformist tendency that is virtuous. If you see something going wrong, that is subject to regulation or legal restriction do it. It is a flaw or a foible that we don't think normally about the costs associated with those requirements. Sometimes it is necessary to tolerate imperfections because the cost of eliminating them is excessive. And this is a broad principle. I'm coming up with it now a bit on the fly, which means that if you ask me, as you should, give me an example.
That was my question, yes.
I am going to fail to do so. But it's something that I've observed very often, a tendency to encrust a particular action with procedural excess intended to prevent abuses or problematic behaviors that end up so restricting people that it can inflict more harm. Let me give you an example where I think this admonition was, there was an excessive, a lesson was drawn that went way beyond what was justified and goes back way in history. And it involved a major economics journal. Back when I was the age of your students, a wonderful drug to prevent nausea during early pregnancy came on the market. It worked. It also resulted in terrible birth deformations.
Take it this is thalidomide.
Thalidomide. Well, as a result of that, we put in place a number, legislatively, a number of regulations to prevent the marketing of drugs before adequate testing for safety was done. There was a major article in one of the 2 or 3 leading economics journals by a professor at your institution arguing that these rules were counterproductive because they delayed the introduction of beneficial drugs, even as they prevented the release of ineffectual drugs, and that the loss of those benefits exceeded the gains. Analytically, that came in for it was a very controversial article. That professor may be still teaching it at Chicago, I don't know. But the point is, it underscores a dilemma that we're facing, for example, now with a drug that was just approved by the FDA for the treatment of Alzheimer's, based on evidence which many find too thin to justify a drug that's going to cost, as I recall, 6-figure annual cost.
I think it was now 56,000.
Was it 56,000? I'm exaggerating then. But it was still a lot of money. And the question was this decision premature? It's for Alzheimer's, which is a cruel disease and provides marginal gain. And isn't there something we should do to help these patients and their families? So one can see the pulling and tugging of conflicting instincts that revolve around how far should regulation go? How easy should it be to approve that particular and many other drugs like it?
You know, one thing that brings out, we won't particularly be able to do this in the class, but when we're trying to evaluate decisions, you can evaluate it from an ex ante perspective where you're taking a calculated risk, or you can evaluate it once the cards are turned over. And, you know, once the card was turned over on thalidomide, of course, it was clear that, you know, we would have not wanted that drug available. And particularly since thalidomide caused tragic outcomes and it prevented, the things that it prevented really were not commensurate with the risks that thalidomide caused.
Sure.
But if you think about, say, new HIV medications or dementia drugs or some drugs for serious cancers, it's a little bit unclear how one wants to, what calculated risk one wants to run. And especially since different people may have different toxicities to a particular drug and so on. And it is a real challenge. And we're going to make mistakes in both directions.
Exactly. Furthermore, there's a research issue here as well. You can evaluate something until it is in widespread random use, at which point, when it's sort of part of the standard medical practice, at which point the best forms of medical research are no longer, the random clinical trial, are no longer ethically permissible. So if you're going to evaluate, you got to do it early. And if you are driven by compassion, that may be persuasive and it may be the right thing to do, but you're sacrificing something also, which is the ability to evaluate it as effectively later on as you could have early on.
There, by the way, I will just mention one thing and then I'll let you go on your day. I should say to students, I ambushed you this morning and forced you on. One of the things that was really striking to me about COVID is the way that COVID is a mirror to so many disparities in healthcare and the ways that people of lesser means have access to less proficient care. And with a doctoral student at Crown and with an intensivist, we interviewed Caroline Kelly and Will Parker. We interviewed key informants about the disparities in mortality rates in the intensive care units around Chicago and some of the things that caused that. And I was kind of expecting going in that people would say, well, at University of Chicago, at Rush, at Northwestern, that the people have access to advanced therapeutics and things like that. And what we actually heard was different. It was, they have more strong humans at the hospitals that I just mentioned, so that when people are in the ICU, they can position the bodies properly when people have trouble breathing and they have acute respiratory distress syndrome. And there were these huge disparities in mortality that came from very, very basic resource disparities that prevented the effective delivery in a routine way of very low-tech care that everybody understood. And the hospitals, the safety net providers, needed those patients in the ICUs financially for the Medicaid reimbursement. Hospitals like ours did not want these patients and actually didn't have capacity for them particularly, but certainly did not want them because they were displacing patients that had higher reimbursement rates. And so probably 25 or 30% difference in mortality rate that just literally came from these very mundane things about, do we have enough people in the ICU as staff to keep people positioned prone, when they have trouble breathing. And it's sort of an interesting mix. Sometimes, there's the new cancer drug, and there's also all the ways that we tolerate disparities in the proficiency of care just because a hospital like ours has more nurses and respiratory technicians and security people and everything else than the safety net providers have. And I think unfortunately, I think the very basic incentive issues that we learned in this course give us a very clear window into why hospitals were treating patients they shouldn't be treating, and also why hospitals were not treating patients that they should have been treating. And COVID was a mirror to stuff that just happens every day that leads people to die in our safety net hospitals and our community hospitals. And so it's sort of interesting that health economics can be very helpful understanding the economics of drug development for, Gleevec or some fancy cancer drug, but also for, are you going to be in a place where they can properly position you on your stomach if you have trouble breathing and you're in the ICU, and you need both things. So
absolutely.
So with that blabbing by me, I will end my interview with you.
Thank you very much, Harold, as always.